and gentlemen. As usual, we will start with a prayer. This is the lecture which I had given at the SOA conference in 2023 December. The topic was challenging, and I have seen that the place where this conference was hosted, Himatnagar, it has been always giving me challenging topics, and therefore I love that place. 1994, 29 years before, they gave me a topic which was very controversial situations in obstetrics at that time. And once again, understandably, I have been given a tough topic because I am a teacher, and a teacher is supposed to handle tough topics. Because if a challenge is not met with, it doesn't change you. And if you don't change, then you are living dead. Therefore, a teacher guides you to a change. A 29-year-old lady was referred from an outside facility on postpartum day 5 with progressive abdominal pain and generalized abdominal distension since last 3 days. She had undergone elective cesarean section, uneventful term Caesar 5 days ago for non-progressive labor. She was discharged as per the hospital's policy on day 2. However, she required readmission on the same day in the evening because of pain. On presentation at this hospital, she had tachycardia of 116 per minute, blood pressure was 110/80, respiratory rate was 30 per minute. So all of these indicate that all doesn't seem to be well, from which a shock index, if calculated, was 1.1. And you all know that a normal shock index should be 1 or less than 1. I will tell you about shock index a little later. Abdomen was grossly distended and tympanic with features of peritonitis, frank case of peritonitis. CT scan was done which showed a pneumoperitoneum, free fluid in the peritoneal cavity, but no clue towards etiology. They all started thinking that it must be an infection of the cesarean section. We always try to think of common things and always try to blame our own selves. After fluid and resuscitation and antibiotics, the patient was taken up for emergency surgery. A midline laparotomy incision was made and a thorough lavage of peritoneal cavity was done. Anterior wall of the uterus was intact, there was nothing there. Anterior wall of cecum was gangrenous and had sloughed off with a perforation measuring 5 by 4 centimeters. The cecum was perforated. Margins of perforation were freshened and primary closure was done in 2 layers. A proximal diverting loop ileostomy was done in view of gross peritoneal contamination. She was managed in the ICU of the hospital. She was lost after a very stormy postoperative course. Very unexplainable. They called this as Ogilvie's syndrome with perforation peritonitis. After cesarean section, in this case, it is acute colonic pseudo-obstruction. All the cases which I am going to discuss today to highlight the academic basis of the talk are true to life cases. They have come from true references. This case came from Bangalore, 2022. Always it makes us think, what is happening? Even the most junior resident, if made to do a cesarean section, would not perforate the cecum so far behind. This was unexplained. Acute colonic pseudo-obstruction is known to occur after operative trauma, infection, and heart disease, especially after a heart attack. You are handling a heart attack and a colonic pseudo-obstruction occurs like this, maybe a cecal perforation. It led to an unexplained perioperative death. Why should this happen? And that is the topic of today, unexplained perioperative death. For a theoretical discussion, to refresh your memory, the textbook definition of perioperative mortality is any death, regardless of the cause, occurring within 30 days after surgery, in or out of the hospital. First 7 days is now classified as immediate. All others are late perioperative deaths. I always call these such deaths as mischievous girlfriends like this. Kills without firing a single bullet. A job professionally done. And everything remains mystery, unexplained. That which is explainable is not the focus of today's discussion. They are all well known, like immediate complications during the procedure like bleeding, perforation, surgical site infection, blood clots leading to deep vein thrombosis and pulmonary embolism, lungs problems, advanced age, strokes during surgery or immediately after, serum albumin levels less than 3.4 grams per deciliter, known to be with increase in mortality. These are all explainable. We know it, we have been taught since a long time. Even the later ones, these were the previous list was immediate ones. The later ones, they are also very well known, but delayed perioperative deaths are always explainable. Let us understand this, and most of the times, 96% of the times, it is related to infection. Other causes are venous thromboembolism, embolism late. It has been found that patients in whom RBC transfusions were given, they were associated with increased risk of adjusted late mortality across all levels, irrespective of the surgery, irrespective of anything else. These don't surprise us, because that is not our topic of focus. The topic of focus is where you are surprised. Why this happened? Let me show you this case. Like the first, oblivious syndrome. Why it happens? See this. Mrs. A had an uneventful, uncomplicated TH. She was ASA 1 case. Anesthesia risk 1 means no risk. Most of these unexplained deaths, I'll be showing you the data, are most of the times ASA 1 cases. And that is where we feel cheated the most. Immediate postoperative condition was apparently uneventful in this lady. But there was a persistent tachycardia around 90 to 110. Relevant investigations were done like routine CBC and similar, which were non-contributing. On the third day, she complained of chest pain and discomfort. She suddenly deteriorated and was lost within less than an hour. Sudden, typical unexplained perioperative death. Her pre-ECG, pre-operative ECG was normal, and intraoperative monitoring continuous was also normal. Prolongation of QT interval, which our physician friends will tell us, can be a matter of great concern, as it may be associated with an increased risk or specific type of irregular heart rhythm, which can degenerate into a ventricular fibrillation in a life-threatening arrhythmia. Preoperative factors not known. This is a case. You may not be able to read the ECG, so I'm making it simpler for you. See this. Typical QT interval prolongation. Here, QT. So, this is what the ECG shows. The QT interval you'd like to know is a segment of ECG that represents the time taken for the ventricles of the heart to depolarize and repolarize. Irregular rhythm, what I had already told you about Torsades de point, which can degenerate into ventricular fibrillation, is very life-threatening. Is this attributable to hypoxia during surgery or in postoperative period? Not likely. Because nowadays, with continuous oxygen monitoring, SpO2 monitoring, real time, a mother or a woman undergoing a surgery in obstetrics and gynecology, I am sure a hypoxia will not be missed nor remain untreated. Is this attributed to surgery? Only surgery? The trauma of surgery? Could be. Can't say. As such cases are very rare and the data is scarce. So let us look at the data. And then you will see the data when you are watching this video. And it happened in that lecture also. You will feel a sense of fear. You will be extremely afraid. Oh, if this happens to me. Because every time something bad happens to someone, we start thinking for us. Oh, if it happens to me. Oh, if it happens to me. Please, don't be afraid. Don't be unnecessarily alarmed. This lecture is not to make you mortified with fear. No. This lecture is to give you information, academic information, that these things also can occur. You read so many things in newspapers, on the net. Everything you don't attribute to yourself. The same mechanism you should apply here. Just get informed that perioperatively, because of these reasons, patient in obstetrics and gynecology can be lost. This is actually what I'm showing you is a retrospective analysis of 17 years in this big institution. 1,700 forensic autopsies over 17 years were analyzed following unexpected sudden death. It revealed a group of 50 cases that could have been related to surgery and or anesthesia. Now, you're all very intelligent people, you will immediately start dividing. There are 50 cases, comes to 3 every year. Unexplained. Once again, your fear complex will take hold of you. But please, what is this institution from where this article comes? It is a huge institution. It has 760 beds with 50 plus surgeries in a day, including emergency surgeries. That comes to 18,000 surgeries in 1 year. Now, you remember, you know this, you can see on the screen once again, that in 17 years, this is a data of 17 years. That means that there were around 3 lakh surgeries in 17 years, of which 50 had unexplained perioperative death. That will give you confidence that, okay, this can happen. Now, let us analyze this data further. Patients were young with no history of cardiac disease. As I told you, all were uncomplicated disorder. Surgery was for uncomplicated disorders, all classified as ASA 1. Now, the timing of the death was examined. It was found that these sudden perioperative deaths, 16% occurred at the time of induction. During surgery, 64%. And at the end of surgery, 20%. This is cardiac arrest, friends. This is a mode of death. This is not a cause of death. Cardiac arrest can occur in this way during these three phases. Cause of death, unexplained. But this data comes from the institution where the concerned legal authorities have a right to ask for an investigation, like a postmortem. And that examination was done on the instructions of the public prosecutor, which revealed none of the typical causes of death were associated with surgery or anesthesia. They were all atypical causes. Let us see them. Of the 50 cases, 47 had cardiac lesions. They were all unexplained perioperative death, which was identified afterwards. Arrhythmogenic right ventricular cardiomyopathy in 18 cases. Coronary artery disease in 10 cases. Structural abnormality of bundle of his in 9 cases. MVP or mitral valve prolapse in 1. And acute myocarditis in 1 case. Remember, before surgery, these were all ASA 1 cases, thoroughly evaluated. So you must be wondering now, why does this happen? Let me recount another baffling situation like this. I'm still wondering why that happened. I was giving a trial of labor to previous cesarean section scar, attempting a vaginal birth after cesarean section. Labor did not progress and patient's general condition also worsened. I opened her up and found a bad rupture. Friends, I have hidden the identity of the hospital here. Not my case, but I am presenting it as if it is my case. I tried to say, but it can happen to me as well. I tried to save the uterus but failed. So I did a hysterectomy. Patient was shifted to the ward. As the surgery was prolonged, there was a big backlog in the outdoor. So I went straight to the outdoor. The ward paramedic was providing me with the info on vital parameters. All seemed to be going well. And suddenly the patient collapsed. What must have happened? On the face of it, everything seemed to be fine. Now, when you want to investigate such a thing and such a challenging lecture, you go deep inside to find the mysteries. After a hemorrhagic shock, which has been tackled, it is advised that the obstetrician should continue to be vigilant even after the vital parameters begin to improve, because such patients may go into a systemic inflammatory response and subsequent sudden shock. And it will be classified as an unexplained perioperative death. There are some tools which can help you in identifying an impending condition. And one I had discussed in one of the earlier slides, and that is shock index. Shock index is heart rate divided by systolic blood pressure. The accepted value is 0.5 to 0.7. And a shock index of more than 1 is abnormal. Now, let me give you an example. Pulse 80, systolic blood pressure of 100, the shock index is 0.8. You are happy about it. Nothing is to be done. But a pulse of 150, systolic blood pressure of 60, the shock index will come to 2.33. So that is how shock index. You might be biased to, oh, the pulse is okay, no? Blood pressure is a little low. Or the BP is okay, no? The pulse might be a little fast. No. Calculate the shock index and write it in the case so that you become aware and alert that, oh, if there is something going wrong, why is it going to go? 2022 paper. The systematic review found a 4-fold increased risk of in-hospital mortality in adult patients with an initial shock index of 1 or more than 1 in emergency department or trauma center. So 4 times she has a higher chance of mortality, whatever, across all lines. If SI is more than 1, be alert. This could be an unexplained perioperative death where you may have some time to find an explanation. I am aware of modified shock index. I am also aware of adjusted shock index, but that is not our topic of discussion today. Now let me share with you one more case, which is sort of an out of control case. Perioperative deaths unexplained, you feel they are many times out of control. A 27-year-old housewife presented at one of the All India institutes with high-grade fever and swelling over both ankles, with a bluish black discoloration for 10 days. She had delivered a healthy female 28 days back by LSCS in a small town hospital and got discharged after 5 days of surgery. 2 days after discharge, she developed fever, which was high-grade, intermittent and without chills. For these complaints, she was hospitalized, received intravenous ceftriaxone and metronidazole for 2 weeks for suspected puerperal sepsis. She got discharged after 2 weeks but continued to have intermittent fever and painful swelling over both the ankles, which turned bluish black in color later on, along with onset of purulent non-foul swelling discharge from the edematous tissue. After admission at the tertiary center, she was found to be febrile, conscious, oriented, pulse 135, blood pressure 142, SpO2 92%, at 5 to 6 liters per minute of oxygen continuously supported. Pale, but there was no icterus, cyanosis, clubbing, lymphadenopathy. On examination, there was cystic swellings over both ankles. I will show you that, with blackish discoloration and pus discharge. Purulent discharge. Look, I'll tell you why it is, I changed the word. The fluctuant swelling of various sizes were found to be below knee. You can see here, typical. It did not stop it there. X-ray was done. Before that, bilateral coarse crepitations were found on auscultation of the chest. LSCS scar was healthy. There was nothing in the abdomen. Abdomen was soft. Investigation showed anemia 6.51, high total count, neutrophilia, platelet count 1,94,000, comfortable, but total bilirubin was 2.33. Creatinine, unconjugated bilirubin of this 2.33 was 1.24. Major component. So it seems to be prehepatic. Creatinine 1, urea 32, RBS 102. Urine examination was normal. HIV, HbSAg also was non-reactive. An X-ray showed this. Bilateral nodular fluffy opacities, multiple variable size and shape nodules were noted, scattered in bilateral lung field, with predominantly in subpleural, peripheral, and septal region. See this. You can see this. A caesarean section. Discharged, came back with this from home. A contrast-enhanced computed tomography of abdomen and thorax showed multiple splenic infarct, splenic vein thrombosis, bulky pancreas, mild ascites, and hepatomegaly. You can start thinking in terms of septicemia. She was put on injection meropenem and tablet coat tribexazole. On 5th day, she further deteriorated and could not be saved. On the day of the death, the cause of death was unexplained. What caused this infection? What caused this morbidity? It was after some time when they went deep into the case and reviewed the material which was collected from the patient that one clue was seen. her blood culture showed Burkholderia pseudomalae, which is a gram-negative bipolar aerobic motile rod-shaped bacterium. It is a soil-dwelling bacterium, endemic in tropical and subtropical regions worldwide. It produces the condition which we call it as milioidosis. Is an important cause of sepsis in East Asia, especially Thailand and Northern Australia. Unluckily, our Indian patient got trapped in it. Usually causes abscesses in lung, liver, spleen, skeletal muscles, and that is where it came out, and parotids. It was a rare case of disseminated milioidosis following lower segment cesarean section, and this case was published 2 years before. Disseminated milioidosis presents with abscess formation in various organs and may or may not be associated with sepsis, as was in this case. The discharge from the fluid of the ankle did not show. This question was asked to me, and I replied there also at the conference. It did not show the routine pus forming organisms. The organs which can be involved, I told you, liver, lung, spleen, even prostate in males. Involvement of joints, even bones, viscera, lymph nodes, skin, or brain may also occur. So, when you have a rare case, you may have it once in life, but keeping a knowledge, not of fear, but keeping of knowledge of what is happening all around may make you a little wiser as to why this happened. Many times you will not be able to explain. Many times you will not be involved in such a case. When you think of rare things, you are rarely correct. So please don't be afraid. But such rare cases are worth keeping yourself abreast of, so that academic, you feel happy that your knowledge is fresh, plus you can give such inputs and or draw conclusions that yes, this could be this could be this. I have heard it somewhere. The answer many times will remain could be. And many times here is a misnomer, because these are rare cases. It is impossible to cover all the causes of perioperative deaths. In the same way, it is impossible for you to know about all of them. And it's an impossible situation many times when you handle it. Some of them will always remain a mystery. But the commonest unexplainable are explained in this lecture on basis of data and events. So what you are expected to do? To be able to understand and explain unexplained perioperative deaths, be alert of what is happening clinically. Be in full command of what is happening by keeping your knowledge well informed and well read. Always. By attending such sessions. That is the software for explaining unexplained perioperative mortality. Then in that case, you can be happy and satisfied for the aim for which you came in medicine. Thank you, ladies and gentlemen, for your interest in this challenging topic. Thank you so much.